Brain death. Brain death is defined as irreversible cessation of the function of the whole brain, including the brain stem, with irreversible loss of the capacity of consciousness, combined with irreversible loss of the capacity to breathe. The cause of brain death are post-cardiac arrest, head trauma, intracerebral hemorrhage or infarction. Regardless of the primary cause of brain death, there is widespread brain edema with subsequent increase in intracranial pressure and an irreversible cessation of blood flow to the brain and brain stem. The final result of this brain swelling is coning that leads to brain stem death. The diagnosis of brain death is by the presence of a cause, as we said before. We have to exclude patients with some factors from the testing. Then we have to go to perform the tests, and finally confirmatory tests. Conditions required before performing the brain stem death testing are the presence of a cause, of course, the presence of apnea and comatose patients requiring mechanical ventilation. The following factors may exclude the patients from brain stem testing, because all these factors may lead to coma and paralysis and wrong diagnosis of brain death while the patient is not in brain death. These factors are hypotension with mean blood pressure less than 60 mmHg, the presence of hypothermia, the presence of metabolic and endocrine disturbances as hypoglycemia and hypothyroidism that may lead to coma, the presence of sedatives and muscle relaxants. So, you must be sure that the sedatives have been stopped enough time before performing the test so that their action has been terminated. And for muscle relaxants, the peripheral nerve stimulator will ensure the presence, or I mean by the absence of any residual effects of the muscle relaxants. And finally, the test cannot be performed in the presence of medical cause of paralysis as Guillain-Barré syndrome. Now, how are tests performed? The test, of course, is performed when the relevant conditions and exclusion criteria have been addressed. They should be performed by two registered doctors. One of them should be a consultant. The complete set of the tests should be done twice by the two doctors together. It's not so important how far are the two tests performed, but what's important is that the baseline parameters should be restored before starting the second set of tests. Tests of brain death. These include the presence of coma, absent brain stem reflexes, and the positive apnea test. For coma, there is absent cerebral motor response in all extremities and face to noxious stimuli, as supraorbital compression or stimulation of nail beds. Second is the absence of brain stem reflexes, and is to be noted that only the first 11th and 12th nerve are not tested in these reflexes because they are not included in the brain stem arc. The pupils, the position of the pupil, or the size of the pupil should be mid-sized to dilated, and there is absence of the response to bright light. There is absence of the corneal reflex elicited by touching the cornea with a piece of cotton. Absence gag reflex by stimulating the pharynx. Absent cough reflex or carina reflex. And finally, the ocular movement. We have two ocular reflexes to be tested. The oculocephalic reflex or the doll's eye movement. And the second is the oculovestibular reflex. As regards the oculocephalic reflex or doll's eye movement, normally when rotating the head from side to side and the brain stem is intact, the eyes will move against the movement of the head, while in brain stem death, the eyes will move the same direction of the head movement. These tests shouldn't be used if suspicious of cervical spine injury. In the oculovestibular reflex, 50 ml of cold water are injected in both ears with 5-minute intervals provided the external canals are patent. If the brainstem is intact, there is conjugate eye movement toward the irrigated solution, which is lost in the presence of brainstem death. Finally, we will go to perform the apnea test. The apnea test should be performed only after normothermy is established. It is defined as absent respiratory efforts when the arterial pressure of carbon dioxide increases by more than 20 mmHg above the patient's normal baseline. This test is the last one to be performed because it may be associated with complications as hypotension, hypoxemia, and dysrhythmias. The test is performed as follows. The patient is pre-oxygenated with 100% oxygen, and the middle ventilation is set to the patient to obtain the normal or baseline arterial pressure of carbon dioxide, but never less than 40 mmHg. Then the patient is separated from the mechanical ventilation, and oxygen is insufflated through catheter introduced in the endotracheal tube and connected to oxygen flow meters to avoid hypoxemia during the test period. 8 to 10 minutes later, arterial blood sample is withdrawn and the patient is placed back on the mechanical ventilation, slightly hyperventilated, and then placed back on his previous settings. The test is considered positive if apnea persists with arterial pressure of carbon dioxide rises more than 20 mmHg. If any complication occurs during the tests, as hypotension, hypoxemia, or dysrhythmias, the test is aborted and arterial blood sample is withdrawn to determine whether the increase in carbon dioxide is adequate to satisfy the conditions of the test. It's not surprising that hypotension is the most common hemodynamic alteration during the apnea test. And this is because in the absence of normal sympathetic tone, hypercapnia causes decline in left ventricular function and peripheral vasodilatation. It is to be noted that spinal reflexes may persist, leading to limb movement. These movements may be distressing to the patient's relatives, but they should interfere with the performance of the tests. Brain-dead patients may exhibit brief spontaneous movements of the head, torso, or upper extremities. It's called Lazarus sign, especially after they are removed from the ventilator. These movements are likely due to cervical spinal cord neuronal discharges in response to hypoxemia or mechanical stimulation. After the movement ceases, the extremities become flaccid. Some clinical features may occur as a consequence of brain swelling and may be associated with brain death. These are third nerve lesions due to herniation of the ancus, sixth nerve lesions due to nerve stretch, since the abducent of sixth nerve is long and tortuous and liable to stretch. The Cushing reflex in form of hypertension and tachycardia may occur as a desperate attempt to maintain blood supply to the brain. This is a baroreceptor reflex. Tachycardia baroreceptor reflex response. Then be followed by various arrhythmias. Endocrine manifestations, namely pituitary failure, however, these don't appear unless few days after brain death and include hypothyroidism that may further exacerbate hemodynamics, central diabetes insipidus, with large amounts of urine osmolality less than 200 milliosmol per kg. Finally, the loss of thermoregulation leading to hypothermia. Confirmatory tests. These confirmatory tests are performed in some countries as the United States. However, in others, as the United Kingdom, they are not performed except in some situations. For example, patients with severe pre-existing lung disease. Such condition hypoxemia will develop during the test and interfere with its performance during apnea test. Another situation is the presence of severe craniofacial trauma, which may interfere with testing the nerves. The aim of the confirmatory tests is to elicit complete loss of electrical activity and blood flow to the brain. Examples of these tests are a 4-vessel angiography. However, it is an old test. The CT angiogram, the MR angiogram, and the least invasive test and bedside test is the transcranial Doppler ultrasonography, which show some change in the velocity or characteristic change in the velocity of basal arteries in the brain. Finally, the EEG, though difficult to perform due to interference from the surroundings and also the auditory evoked potentials. What is the legal time of death? This is the time at which the first set of tests is completed. However, the patient is not actually pronounced dead until after the second set of tests have been performed. In some countries, brain dead patients are potential organ donors. So, in such circumstances, it's very important to perform measures to enhance organ viability, both regarding hemodynamics and pituitary failure. For hemodynamics, the presence of hypotension with mean blood pressure less than 60 mmHg or urine output less than ml per kg per hour or reduced cardiac output should be corrected with fluid keeping the central venous pressure at 6 to 8 mmHg. This will be followed by either dopamine to treat hypotension or dobutamine with reduced cardiac output. However, the vasopressor dose should be minimized to help maintaining organ perfusion. For pituitary failure, desmopressin, which is a vasopressin analog without vasoconstriction, is used for central diabetes insipidus, keeping the urine output about 100 to 2 ml per hour. Some patients may develop hyperglycemia due to excessive use of glucose to treat diabetes insipidus. This hypernatremia, diabetes insipidus. In such condition, insulin is required to maintain serum glucose between 80 and 150 mg per deciliter. Finally, the patient may require hormonal replacement therapy in the form of methylprednisolone and triiodothyronine when blood pressure and cardiac output remain depressed despite hemodynamic optimization.